On the screen at the moment, you can see a biconvex hypertensity. The bleed that is shown in red color is on the left hand side, and this is causing a significant pressure on the ventricular system. And therefore, what will happen in this case is the distortion of the ventricular system also. So what I've tried to show in this particular, I would say, animation is the midline shift or like a subfalcine herniation. If you have listened to my discussion of raise ICP, I have explained the whenever the hematoma will expand in size, it is going to cause a midline shift. So just check it out once again. There is expanding hematoma. It's going to put pressure on the ventricular system, and this is going to cause distortion of the ventricular system. The contralateral horn dilation is present in this case. So I've tried to highlight midline shift. What I've tried to highlight is subfalcine herniation, that is a horizontal displacement. And then I've also shown a CT scan in which there is a biconvex hypertensity. Even a little lateral to that, what you can check out is a subperiosteal bleed, because he fell down. So there is some evidence of subperiosteal bleed, but that biconvex hypertensity is very hard to miss. So this was mainly to explain to you how the image can be given. It would be very peculiar shape of biconvexity present. And now we will focus on the treatment part. The treatment is also based on the fact that there is an acute deterioration happening in this case. The source of bleeding in this case is, anyway, if you are familiar with that, that is middle meningeal artery. In fact, in the exam, what he did was like middle meningeal artery, branch of internal carotid, branch of external carotid artery. So from the anatomy perspective, you would be aware that middle meningeal artery is not a branch of the internal carotid. It is a branch of the ECA, that is the external carotid artery. As far as the management of this case is concerned, how would you manage this? Then option would be Burr hole also, and the options would also talk about a craniotomy. Well, the main treatment of this guy would be rapid surgical evacuation. Because of the acute deterioration that is happening in this patient, we would be doing a rapid surgical evacuation by craniotomy. And along with this, what we also need to do is ligation of the bleeder. So both things have been asked in the exam, like what is the best management of a person of extradural hemorrhage who's having an acute deterioration? Your answer would be rapid evacuation. That would be done using craniotomy with ligation of the bleeder. I need to get the pressure off the brain in this case, and simultaneously we need to do ligation of the bleeder. The bleeder here is the middle meningeal artery, which is a branch of the external carotid artery. Now, lots of time it might so happen in my hospital that the neurosurgeon is not available at the moment. He stays, let me say, 1 hour away from the campus. So it's taking time for him to come, or he's already in the OT, but he's doing a case. So he says, boss, it will take me like 2 hours for the case. So in those circumstances, when a neurosurgeon at the moment is not available, what we can also do in this case is Burr hole surgery. And Burr hole surgery is only to be done in case there is development of posturing in this patient. So especially if he's going to give me a case when he's going to say that the person had an extradural hemorrhage, there is a deterioration to the level that there is even posturing occurring in this case, then what I am going to do in this case is a Burr hole surgery. That is going to help me in buy some time for the patient. But suppose in a question he mentions regarding Burr hole also and rapid evacuation by craniotomy, then the single best answer that we will give in the exam would be that we'll do a craniotomy in this patient with ligation of the bleeder. And only if he specifies the fact that due to administrative reasons or due to logistic reasons, if we are not having the facility for craniotomy, there is a posturing occurring in a person, EDH patient with posturing, that is in an emergency scenario, that is when we can be doing a Burr hole surgery. The site for Burr hole surgery would be the TDON, but then he put up a very interesting question in the exam. He said, like, how would you decide on which side would you be doing a Burr in absence of a CT facility being available? See, what I want you to understand is that we are a resource limited country. So in those circumstances where I do not have a CT scan available, what I can rely on the finding is with respect to the midbrain, that there is a Dinger vestibule nucleus, then we have an oculomotor nerve that's supplying the 2 eyes of the patient. It's the efferent arc of the light reflex. So I'll be shining a torch in the eye of the patient on whichever side the bleed is present. On that side, you will notice that because there's a expanding hematoma which is putting pressure on the oculomotor nerve, there would be a pupil that will be showing a sluggish reaction to light. What will happen in this patient is on whichever side the bleed is present, like in this particular case, you can see on the right side there is a bleed present. So it's going to press on the right-sided oculomotor nerve, and therefore you'll have a mid-diluted, sluggishly reactive pupil. And I've spoken about it even in RAISE ICP, that is Hutchinson pupil. So if the bleed is gonna be localized to this particular side, that is the right side in this particular case, even if I don't have a CT scan facility, I can still be doing Burr in an emergency situation on the same side. So the message here is how to decide the size of Burr hole in a EDH if CT scan is not available. The answer would be do the Burr on the same side on which the Hutchinson pupil is present in a patient. I repeat my statement. On which side would you be doing a Burr? Your answer would be given as on the same side, that is ipsilateral side 2 of that of the Hutchinson pupil. And what I'm trying to explain at the moment is that the decision of Burr hole ideally should be based on a CT scan report, but if it is not available, then as I said, it is ipsilateral to the side. I mean, whichever side, how do I know whichever side the bleed is? On the same side on which Hutchinson pupil is present is the side where the Burr hole surgery would be done in the case. Having said that, what we'll focus subsequently is aspects related to subdural hemorrhage.